Yeah, thank you. So, good evening, good afternoon, and good morning to all of you who have joined today and to yet another session of advanced management of thalassemia care. This is our session 10, which we are organizing with Thalassemia International Federation and Thalassemics India. And today's program is so every month we take up a topic which is on multidisciplinary care in thalassemia. So we've finished cardiology, we've finished bone health, we've finished fertility. These issues were covered in the last few months. And today we are discussing liver disease in thalassemia. So for an overview of the program and on why liver disease is important as a major determinant of morbidity in patients with thalassemia, I would request Dr. Andrula Eleftherio to give her remarks. Madam is president of the Thalassemia International Federation and an advocate for people with thalassemia across the globe. Over to you, Dr. Eleftherio.
Thank you so much, Dr. Nida. I'm so proud of this work that you are doing in this past months and throughout the year. And on behalf of the Thalassemia International Federation, it is my pleasure and a great honor to introduce Professor Dushego to start with, and to welcome you to this webinar series, all of the participants, focused on advances in thalassemia care. And as you very well indicated, multidisciplinary care is very important, and liver disease is a key determinant of the health and morbidity and mortality rates in this population. Allow me to take this opportunity to warmly thank the Postgraduate Institute of Child Health in Nodi, as well as Dr. Nida Rakirshan in particular, for her ongoing passion and commitment to improving both the health and the services provided to these patients and related disorders. But I would also like to greatly acknowledge ECO India, along with a distinguished member organization, Thalassemics India, represented today by a dear friend, distinguished, long-standing member of the Chief Board of Directors, Mrs. Shobha Turi. We are truly impressed by the work carried out through this webinar series and spans a wide range of medical disciplines and now appropriately turns its focus to liver disease. There could be no more suitable speaker than Professor Dushego, who has been a pioneer in the field and played a key role in the establishment of TIFF's first international academic panel dedicated to liver disease. Liver disease remains a critical medical complication in these disorders, and in particular in transfusion-dependent thalassemia, and not only, and affecting not only children and adolescents, but also an increasingly aging patient population as the patient population ages. It encompasses a wide spectrum of challenges, including viral hepatitis, iron overload, of course, due to inadequate or suboptimal chelation, and in particular, multifactorial causes, all of which Professor Dushego will elaborate on his presentation and integration in the discussion. As Thalassemia International Federation, we fully support the work of our collaborating center, the Postgraduate Institute of Child Health, and we commend the dedication and scientific leadership that has been made this initiative possible. All of the healthcare professionals and scientific staff that took part and continue to take part in this series. So we remain firmly committed to strengthening such collaborations, which play a vital role in advancing knowledge, improving clinical practice, and ultimately enhancing the quality of care delivered to the patients that we represent. We look forward with great interest to the discussions that will unfold today, as well as to the conclusions and practical insights that will emerge from this important webinar. I welcome all participants and wish them a productive meeting. Thank you.
Thank you, Dr. Eleftheriou, for those introductory remarks. Now, I would like to invite Mrs. Shobha Tuli. Mrs. Tuli, in an Indian setting, does not require any introduction. She is founder of the leading thalassemia support, one of the leading thalassemia support organizations in the country, which is Thalassemics India, which is working nationally towards the cause of children with thalassemia. She's been strengthening patient network. She's been instrumental in advocacy and especially for engaging with the government for policies related to thalassemia care. Over to you, ma'am, for giving an insight on why liver disease is important for our community here.
Thank you, Neeta, for your kind words. I once again welcome Professor Dusheko and my friend Dr. Nrula Eleftheriou and all the delegates who have joined today to be here on the session 10, which is very, very important as far as thalassemia care and management is concerned, which is the liver disease in thalassemia. And today we'll have an opportunity to hear about the assessment, prevention, and management in detail. All the delegates who are here, they all agree with me that liver disease in thalassemia is a major, major complication as far as thalassemia management and treatment is concerned. And this is primarily caused by the iron overload and chronic viral hepatitis, which is HBC and HBV. We will hear that how the strict iron chelation and the regular monitoring are crucial as far as this liver disease is concerned. I will just like to share with you my Indian perspective because we have the experience of nearly 4 decades of working at the grassroots levels. I remember in 1990s, we had arranged a talk on hepatitis C when I came back from London after meeting Professor Dr. Wonky and coming back from one of the TIFF conference, which was held in London. And at that time, in India, we were not talking about hepatitis. So we arranged a talk in one of the hospitals. And there were about 40 doctors coming from all over the country and listening to the experts. And I remember that once that talk was over, some of the doctors who were from the same hospital left in between. And later on, I came to hear that, that Mrs. Tulli has come up with something, very new thing, which is not prevalent in our country as far as thalassemia care and management is concerned. But now, in 2026, and during the course of this year, we know that what importance does this hepatitis and the liver disease is as far as the management is concerned. At the same time, my experience is when we meet the families who have gone through these liver problems in our country, and they somehow, try to defer the treatment, even if it is available, they can afford it. They would like to postpone it to wait. Maybe some miracle will happen. Maybe some other therapies would work out. So this is something I want Dr. Neeta, maybe at the end of that session, we will have the expert advice from Dr. Dusheko. But at the same time, we have to understand in our country, there are certain major challenges, since we all know about the level of blood safety, which is not universal in our country because of the high cost. NAT is not there, and even in the NHM schemes, so some part of the treatment liver disease is not covered under that. Apart from that, the high end investigation. So there are certainly some challenges which we are facing, and we have to see that how we can overcome. But at the same time, I would, through this webinar, the message that I feel is we have to give it to our patients and parents is that, well, the treatment is available. It is much improved now, which we are going to hear from Professor Dusheko. So why delay the treatment? At the same time, we have to look at how we can prevent, onset of this liver disease. With these words, I will stop here and hand it over to Dr. Neeta, please.
Thank you, ma'am. Now we would request our speaker for today, Professor Dusheko, to kindly start his deliberation.
Thank you very much, Dr. Radha. Thank you very much, Dr. Eleftheriou, and thank you very much, Mrs. Tuli, for the very kind invitation there. I don't think there are any better examples in medicine where patient care, clinical science, improved science, and patient support and advocacy are integrated in the way that they are with thalassemia. And this has been under the leadership for many years of TIFF, Thalassemia International Federation, and all its worldwide affiliates are clearly very closely aligned. So thank you very much for the invitation. I'll try and give you a brief introduction of liver disease and thalassemia. May be able to share my slides. Thank you. I hope you can see the slides. So I'm going to talk about the assessment, prevention, and management of liver disease in thalassemia. Clearly, as this audience knows, that progressive liver disease is a hazard in thalassemics. The causes are multifactorial. The main cause, and probably the most prevalent cause today, is iron overload, and sometimes, but fortunately not very commonly, chelator-related liver toxicity. But there are a number of ancillary causes of liver disease in thalassemia where a so-called second hit will clearly aggravate and amplify the liver disease. This is mainly due to the chronic hypertrophic viruses, particularly hepatitis C, hepatitis B, and to some extent hepatitis D, and occasionally hepatitis A and hepatitis E, which can cause chronic liver disease, which can affect the liver. But the main causes are, of course, hepatitis B and C worldwide. We are seeing metabolic syndrome or metabolic associated steatotic liver disease in patients who have a high BMI and might have metabolic syndrome, including diabetes and hypertension. There are occasional cases of pancreatic cirrhosis, and alcohol in some patients is a factor leading to progressive liver disease in thalassemia. One gap in our data at the moment is the true epidemiologic burden of liver disease in thalassemia. And I've discussed this with TIFF before. We have extensive data pointing to the liver-related morbidity and mortality in thalassemia. That's not in question. But I think we need more recent updated data to fine-tune what is the etiology of chronic liver disease, what is causing cirrhosis in patients with thalassemia in different geographic regions, and how can we reduce that burden? I think there is a data gap. I think it's important also to possibly separate out the liver disease that we might be seeing in an aging population with thalassemia, and that's indeed a truly a testament to management of thalassemia that we have an aging population with thalassemia in the high-income countries, but it may be different where the pediatric disease and disease in younger individual in resource poorer regions is different and equally important. So we need data in the high income versus the low income countries that will truly reflect the burden of liver disease in thalassemia. The diagnosis and monitoring of liver disease in thalassemia should be relatively straightforward and can be done by non-specialists. In a specialist clinic, but this is equally done in non-specialist centers, a general assessment is made with a standard history and clinical examination. There are a number of standard routine laboratory available tests, which are not expensive, which enable us to monitor patients with thalassemia in most areas of the world. And they include the liver enzymes, the aminotransferases. We'd like to include the alkaline phosphatase and the gamma-GT. The bilirubin and albumin are true tests of hepatic synthetic functions, so they're important. We would have to do a full blood count. That's bread and butter standard for a patient with thalassemia, but the platelet counts might reflect portal hypertension and hypersplenism. Renal function tests are important in patients receiving chelating agents and also, of course, patients receiving nucleoside analogs, and they would be part of routine care as well. Testing for chronic hepatitis C and B and viremia in these patients we can perhaps elaborate on later, but the tests are straightforward, well standardized, and the enzyme-linked immunoassays are inexpensive. And in India, you have been leaders in the world in providing accurate monitoring of hepatitis B and C with the now inexpensive hepatitis B DNA and hepatitis C RNA tests, which are the tests of viremia. Serum ferritin, as all those who look after thalassemia would be part of the routine monitoring of patients with thalassemia, but it is also a liver function test in some ways. Sometimes we might have to turn to specific etiologies, looking for autoimmune disease that can complicate chronic viral hepatitis, including hepatitis delta. We use imaging regularly. We've tried to bypass imaging with non-invasive scores such as the FIB4 and the APRI scores, which take into account aminotransferases and platelets, but it's not clear to me how well standardized these tests are for patients with thalassemia. But importantly, we would rely on ultrasound as a test of structures of the liver, complications of the liver for HCC, hepatocellular carcinoma surveillance, and we'll talk about transient elastography or FibroScan for monitoring liver disease. And of course, in thalassemia patients, we would proceed to the other tests as indicated, particularly MRI for measuring liver iron concentration, but also for monitoring for hepatocellular carcinoma. So thalassemia and chronic hepatitis B are interwoven. Fortunately, better blood screening for hepatitis B has, to all intents and purposes, in many parts of the world, eradicated hepatitis B from the blood supply, and it's no longer a hazard. But for older patients who've been exposed to hepatitis B, chronic hepatitis B is still a problem. And there are, of course, gaps in testing in some transfusion services. The disease is relatively easily managed with maintenance suppressive nucleoside analog therapy. Treatment is straightforward. We have a choice of generic tenofovir or generic entecavir, and in some parts of the world, tenofovir alafenamide. The idea is to suppress levels of hepatitis B DNA to undetectable levels, improve the transaminases, reduce the molecular events that presage hepatocellular carcinoma, including integration of the hepatitis B virus, and there is a swing towards early treatment of hepatitis B, avoiding what might have been used before, the supposition that there are a group of patients who we should not be treating, who do not need immediate treatment. I think most of the recent guidelines, particularly those of the WHO, strongly suggest expanding the criteria for treatment and avoiding the term of who not to treat for hepatitis B, as we can reduce complications. For hepatitis C, there have been remarkable advances in treatment, and India will be well versed in the curative oral direct acting antiviral therapies that have been widely available and have made an important contribution to eliminating hepatitis C in the population at large, and also eliminating chronic hepatitis C in the thalassemic population who were overexposed to hepatitis C because of their transfusion requirements. Treatments are generic. Again, India has led the way with these generic treatments, and the RNA testing for hepatitis C and the generic treatments have made these therapies for hepatitis C affordable with very high rates of cure, which have transformed our management of hepatitis C. For hepatitis D, and I'm a little unsure whether we have a good idea of the prevalence of hepatitis delta and hepatitis B positive individuals in India, but treatments are improving, although they remain expensive, and in our current state of knowledge, still maintenance suppressive therapy. But we have been able to improve on interferon treatment for hepatitis D with new agents such as bulevirtide. Sometimes hepatitis A is a hazard in patients with chronic hepatitis and thalassemia, and also hepatitis E. The important issue that all those of you who care for patients on a day-to-day basis with thalassemia will know is the iron overload. So the monitoring of iron overload, as you know better than I do, is inevitable. We have monitoring tools, which I think we will discuss in some detail, but clearly the everyday monitoring tool that we would use, and I think supported by the TIF guidelines, are serum ferritin measurements at regular intervals. This is an easily available test. It's done on serum, and we can use serum ferritin to give us a good measure, at least, of trends in iron burden of the liver. I believe that in India, the most widely used MRI technique for measuring liver iron concentration would be the MRI T2 star, but you can inform me. And this would measure both liver and cardiac iron concentrations. And MRI is greatly preferred over liver biopsy because of the invasive nature of liver biopsy for routine monitoring of liver iron concentrations. So as this audience knows, we're able to assess with reasonable certainty, although we do require some standardization across the different regions of the world in liver iron concentrations using MRI T2 or RT methods. And I think these would be the accepted standards also published by TIFF of where we can measure by MRI liver iron concentrations expressed as milligrams per gram of dry weight, and what would be seen to be a measure of iron overload severity. Ideally, we would like to keep the iron concentrations below 3. This would be a safe range with a minimal risk of iron-related liver injury. 3 to 7 might reflect mild overload, reflecting early hepatic iron deposition, usually asymptomatic, but obviously requiring intervention. Moderate and severe iron overloads are reflected by concentrations greater than 7, where there is a well-documented risk of increasing progressive liver fibrosis and endocrine dysfunction, and a link to cirrhosis and liver failure. So the serum ferritin, I believe I'm in accordance with the guidelines of the publications from TIFF here, should be conducted regularly, at least every 3 months, or shorter or longer frequency as needed, based on trends in the iron overload level and the iron chelation modifications. So this helps in the prevention of iron overload. It's a simple, widely available test, but it is an indirect marker of iron overload. It's easy to assess repeatedly, it's inexpensive. Trends should help in monitoring the patient. Long-term control, I think, has been linked to outcomes of liver disease and reflects in part exposure to non-transferrin iron. It is an indirect estimate. Ferritin is an acute phase reactant, and for those of us who care for a wide variety of patients with liver disease, we know that the ferritin will go up with inflammation. It cannot determine the iron balance directly, and there may be a non-linear response to iron load at very high levels, and there may be possibly some concern about how well the ferritin will reflect iron levels in patients with an aging liver or patients who already have advanced fibrosis and cirrhosis. Nonetheless, it is a widely used test. Its relationship to iron load is useful, although this can vary with the chelated type. And we do need to be cognizant, however, of some of the limitations. So some of those limitations are that infection could increase the iron levels. So could any cause of inflammation of the liver, including acute hepatitis, and liver disease, particularly steatotic or fatty liver disease, as it used to be called, metabolic associated steatotic liver disease, is characterized by high levels of ferritin in the liver. So that could be a potential confounder. It's probably a poor predictor of individual liver iron concentration, but I would believe that, as your experience would show, that the trends in ferritin can reflect progressive iron accumulation. It does require laboratory testing, but it's a straightforward test. It's used, therefore, for trend monitoring, and probably, ideally, in patients on the cusp of more complex iron overload, should not be used alone to quantify the liver iron. Which brings us to the MRI techniques for measuring liver iron, which you will be familiar with. My understanding is, but you will have to inform me, that MRI T2 star would be the most widely used technique in India, but I'm not sure how universal this is in India, who pays, and what might be some of the disadvantages. But clearly, there is a great body of physics behind the technique. The T2 values using algorithms are converted into liver iron concentration using validated calibration curves, and the technique is widely available. It's non-invasive, doesn't involve radiation, can be repeated frequently, and as you know, is repeated frequently to monitor iron and would allow simultaneous cardiac iron measurement. So this has very strong clinical relevance, with perhaps the proviso that I'm still on a learning curve. How well standardized are the measurements across different units, and do units get together to do comparative studies to guide and monitor for the individual patient iron chelation therapy? And the Ferry scan, again, you'd have to advise me which of the two techniques is more widely used in India, uses a slightly different physical principle, but there is software which is commercially available, which has been standardized and FDA approved for whole liver iron concentration measurements. I believe this would have a higher cost, and this may be applicable in India, requires external data processing, and possibly, at least in some parts of the world, is less widely available. What other simple techniques can we use to measure both progressive hepatic fibrosis or possibly iron overload to a dangerous level in patients with thalassemia? We use transient elastography routinely in all our patients with liver disease, and particularly for chronic hepatitis B and C, for metabolic associated steatotic liver disease, for autoimmune liver disease. We have well-established cutoffs with good trials comparing the findings to liver biopsy that enables us to say with some certainty which patients have advancing fibrosis or have reached a level of fibrosis in the liver that is concerned. The technique is non-invasive, again, widely available, and is highly portable. So transient elastography, however, measures liver stiffness. It measures hepatic fibrosis indirectly by the speed of propagation of the shear wave. It does not reliably measure liver iron concentration. As far as I know, there are no validated liver iron cutoffs that can be correlated with a fibroscan or transient elastography reading. One can make some inferences that there are correlations between a rising ferritin level and ferritin level cutoff point and advancing hepatic fibrosis determined by transient elastography. And one could use this perhaps as a starting point for iron chelation therapy in patients, but we have to remember we're measuring liver stiffness, we're not measuring liver iron concentration by this useful technique. And of course, FibroScan can be confounded by some inflammation in the liver, particularly if the aminotransferase levels are elevated, as we might see in an acute hepatitis. That would elevate the FibroScan reading. It does not reflect fibrotic liver disease at that stage. But it is useful, as abnormal results may be an indirect pointer to high iron overload. Liver biopsy is previously used to ascertain iron overload, both by measuring iron concentrations by atomic absorption spectrometry and by simple staining using the Pearl stain. You can see this blue staining for iron in diseases such as hemochromatosis and thalassemia. It's clearly an invasive technique. It carries a risk of bleeding and sometimes fatal bleeding, of puncture of the gallbladder, puncture of the kidneys, puncture of other organs, etc. It's an unpleasant and discomforting procedure for patients, and we certainly don't use it routinely to ascertain iron overload. I think few centers would ever envisage biopsy for patients with thalassemia. They'd rather use the indirect measures, particularly MRI and ferritin. But in puzzling cases where we might perhaps be underestimating iron overload or fibrosis in complex cases, occasionally we will recommend biopsy. We can also rely on a transjugular liver biopsy in specialist liver units, where the technique is somewhat less invasive and carries a considerably lower risk of bleeding. So that's a fallback measure for more complex cases, but it's no longer used routinely to ascertain iron overload and has been replaced by MRI. I'm talking to an audience who daily apply iron chelation therapy and who know much more than I do about iron chelation. But clearly the chelation would be designed to balance the rate of iron accumulation by increasing the iron excretion, reducing the iron burden in the liver, the oxidative effects of iron, the toxic effects of iron that would lead to progressive hepatic fibrosis. And that's part of this emerging science of the management of thalassemia. So this is an audience cognoscentes, and I can only quote back to you your own very well established guidelines suggesting, I think, a trend towards recognizing that the high liver iron concentrations are linked to hepatic fibrosis. As I said before, the ferritin is useful. That trend might be helpful, but liver iron concentration should also be determined by MRI scan if the ferritin deviates from expected trends, or in more complex cases, the ferritin alone may not be sufficient. So the time points and iron concentrations at which the comorbidities start are not well defined, but I think we have outlined some of those earlier. And although the guidelines might have been a little on the conservative side previously, generally recommending that therapy not be started until ferritin levels reach 1,000 nanograms per ml, early pediatric prevention might reflect a shift in the pendulum to avoid iron overload. And I think I'm reflecting the guidelines to suggest that the chelation should begin after the first 10 to 20 transfusion, or when the ferritin levels approach 1,000, or when the MRI liver iron concentration is 3 to 5 milligrams. So to try to maintain low ferritins and good liver health. There are a number of studies, some of which are older studies, which have indeed shown that regular chelation with appropriate monitoring in quite a large sample of patients with beta thalassemia, using histologic analysis of biopsy samples taken at baseline after 3 years of treatment, that indicate chelation reversed or stabilized hepatic fibrosis in the majority of patients with iron overload, beta thalassemia, and these data, column charts and scatter plots show the absolute changes and the benefits of chelation. So in the last part of this talk, I'm going to briefly summarize what we know in general of this cascade, this pathway of hepatic fibrosis in patients where cirrhosis is an end stage of all advanced liver disease, where the most feared complication is hepatocellular carcinoma. And thalassemia patients are not be immune to this if they carry a large burden of iron overload or a long-standing burden of chronic viral hepatitis, which has been untreated or ineffectively treated. So we know from progressive liver biopsies, and these are samples taken from patients who have chronic hepatitis C. I'm grateful to Pierre Bedosa, and show in fact the various stages of fibrosis with portal-portal linkages, then bridging fibrosis, encircling the liver parenchyma to result in these cirrhotic nodules. The blue is fibrotic tissue. You can see the whole architecture of the liver is disturbed. And here you can see this macroscopic picture of a nodular cirrhotic liver with deeply disturbed architecture, portal and hepatic arterial blood inflow, and of course, an oncogenic process at work at a molecular level, as well as the impaired liver function. That impaired liver function, and here you can see a cirrhotic liver. It's a small, shrunken liver. It should occupy this whole bed, but it doesn't. You can see this crenated irregular edge, and you can see this fibrotic tissue, and you could also see the large spleen as a result of portal hypertension. At this stage of cirrhosis, and cirrhosis does have many stages that can be present without any evidence of decompensation. The patients have not developed fluid overload. This is ascites, as shown in this patient, or had a variceal bleed, or developed hepatic encephalopathy. But this is a stage that we would want to avoid in thalassemia. It represents a failure of medical management of the liver disease, and I hope would, despite the success and an aging population of thalassemic patients worldwide, that this is becoming increasingly less common in patients. But you will have to advise me. We do need to collect epidemiologic data of the burden of liver disease in countries such as India. What numbers of patients are presenting with cirrhosis, as evidenced, for example, by FibroScan, and what numbers of patients are presenting to you and to us with decompensation, with variceal bleeds, or with hepatocellular carcinoma. How do we monitor cirrhosis and portal hypertension? It would be the same for thalassemic patients as it is for all other patients. We want regular imaging of the liver for hepatocellular carcinoma and surveillance. There are certain paradigms which presage a higher risk, but they're not very well worked out. We know that in patients who don't have cirrhosis, and that would include patients with thalassemia, we can predict a high negative predictive value of the risk of cirrhosis, but our ability to predict positively hepatocellular carcinoma is not very high. But we rely on regular 6-monthly imaging and alpha-fetoprotein measurement to detect early hepatocellular carcinoma. We also would ask patients to have an endoscopy to look for esophageal varices. We can measure portal pressures, but it's simpler to look by upper GIT gastroscopy for esophageal varices at risk of bleeding. And we can, of course, measure in specialized centers portal pressure measurement. Our management of the esophageal varices relies on beta blockers with some success. sometimes endoscopic procedures to band varices that are bleeding, and sometimes we use a shunt to divert the pressure away from the esophageal varices. And this slide shows, in fact, the various measures we have for managing advanced liver disease and esophageal varices, where we can ligate them, we can sclerose them, or we can do a TIPS, which is a transjugular intrahepatic portal systemic shunt, connecting the portal vein by a Dacron bridge to the hepatic vein, and therefore reducing the pressure in the portal venous system and the risk of varices. Our most feared complication in patients with liver disease is hepatocellular carcinoma. And again, we would need good data from India to know what is the risk to your patients with thalassemia of HCC, what has been the contribution of iron overload, hepatitis B, hepatitis C, and perhaps hepatitis delta. But we know that there has been an increasing incidence in transfusion-dependent thalassemics, perhaps because of increased reporting. Chronic viral hepatitis previously played an important role. Hopefully that's decreasing, but it's not eliminated. It may also occur even in patients on treatment for the hepatitis B or in cirrhotic patients after they've cleared hepatitis C virus. These patients need to be kept on surveillance. There may be an important adjunctive role of iron overload in the absence of cirrhosis, putting patients with thalassemia at increased risk. There's an important role of metabolic-associated steatotic liver disease, and sometimes we will see hepatocellular carcinoma in non-transfusion dependent. The idea of surveillance is to spot small hepatocellular carcinomas, typically less than 5 centimeters in size, as shown with the scan. These patients would have further diagnostic evaluation, but we can detect these small tumors by a combination of regular ultrasound and alpha-fetoprotein screening. In the at-risk patients, this is done every 6 months, and that should include thalassemic patients who have known cirrhosis. But when the tumor is small, there are a variety of ablative techniques and also curative techniques, including resection of the tumor or liver transplantation, that we would regard as curative. But it does depend upon identifying patients at risk, having a good surveillance program with good adherence to surveillance, and an intervention if small tumors are found. This is a complicated slide, but it's the classic Barcelona Liver Cancer Center schema for staging hepatocellular carcinoma. If the tumors are very advanced, they're large tumors, there's very little that we can do, and certainly we cannot regard any treatment as curative. We rely on arterial embolization of the tumor or systemic treatments to hopefully palliate the patients. Our wish would be that we can detect early treatments where our first treatment options are curative for small tumors, and we can rely on ablative techniques, resection, or even transplantation, but it all depends upon early diagnosis. So to summarize, prevention and treatment of liver disease, I think we're getting there. For thalassemics, importantly, we have improved blood-borne virus testing, and hopefully this is translating into an almost zero risk, in fact, of thalassemics acquiring hepatitis B and C in this day and age. We, of course, can vaccinate against hepatitis B. We've got generally safe and effective iron chelation to prevent the iron burden. We have an increasing interest in the treatment and prevention of metabolic-associated steatotic disease. All of these can slow or even reverse hepatic fibrosis and prevent a point at which cirrhosis becomes irreversible and incurable. And we can rely on secondary prevention of complications of portal hypertension, but we would ideally like to avoid late advanced liver disease. And we can rely on early detection of HCC through surveillance and hopefully curative options. So I think thalassemia exemplifies where supportive care and multidisciplinary approach, approaching the chronic viral diseases, the ancillary diseases, and of course the iron overload, will prevent the complications of liver disease. The iron overload and liver disease can be prevented, as you know better than I do, by individualized iron chelation regimens, strict adherence and monitoring of chelation, and the importance of regular iron determinations. I think the outlook for patients with thalassemia and liver disease is improving with these improvements in iron control, screening for hepatitis viruses, vastly improved treatments for hepatitis B and C, some improvement in the management of advanced liver disease. Liver transplantation is certainly a consideration for thalassemia patients. Appropriate surveillance and monitoring and multidisciplinary approach is important. And I suppose the bottom line is it's always better to prevent cirrhosis through appropriate early treatment and monitoring of patients with thalassemia. And I guess my last statement would be, it would be very helpful to have more data on what is the real burden from liver disease now in countries such as India in thalassemics. Thank you.
Thank you, Professor Dusheko, for that comprehensive discussion on all the aspects of liver disease in thalassemia, from iron overload to viral hepatitis to risk of hepatocellular carcinoma, and how to prevent it, and as well as the management aspects. Now, for the next part, we have some questions in the chat, but before that, we have few case scenarios, which are common case scenarios that we encounter in our population. We have put it up so that we can discuss it. We can discuss the case, the usual issues with you first, and then we will take up the questions from the panel. So I would request, yeah. So we have 3 case scenarios, and these are again common scenarios. One, we have put up a case of a chelator-related toxicity, and we would request your suggestions on how to manage, how to follow up for liver function while we are on, while we give iron chelation. The second scenario is on viral hepatitis. And third one is an iron overload, which was probably poorly managed in the beginning, and that results in almost a decompensation by early adulthood. So the first is a 12-year-old boy with a transfusion-dependent thalassemia. His current, the chelators that he is on is deferoxamine and deferriprone. The doses are 30 and 60 milligrams per kg. And he's come with fatigue and asymptomatic when routine liver function shows high total bilirubin and direct bilirubin with the enzymes that are also high. His ferritin is around 1800, and ferritin is actually lesser than which was recorded previously. So when we encounter, so even in a patient who's just being followed up with routinely without any symptoms as well, we find common phenomenon in the liver function. So what are the key differential diagnoses for transaminitis in thalassemia patients who are receiving chelators?
You would like me to speak first? Is that correct?
Yes, sir. Over to you, sir.
Well, I think we have quite well standards for what we call DILI, the possibility of a drug-induced liver injury. And clearly, and I think you know more about this than I do, but the deferoxamine is the major culprit here. If you go to a database called LiverTox, they list the toxicity for this chelating agent, and around, I think 5% of pediatric patients will have an aminotransferase elevation of more than 5 times. And disturbingly, there are reports of very severe hepatitis, fulminant hepatitis. So this could be chelation-related drug-induced liver injury. We sometimes, in investigational trials and other things, would want to exclude other causes. So we'd want to exclude an acute hepatitis. And that means testing for acute hepatitis A, acute hepatitis or chronic hepatitis B, the same for hepatitis C. In India, I think you'd want to test for an event such as acute hepatitis E virus as well. All that comes into it. It's not difficult to do autoimmune markers to measure anti-smooth muscle antibodies, anti-nuclear antibodies. I think that there could be other causes, Wilson's disease, that we would routinely add in to an investigation where we are concerned about a drug-induced liver injury. So that would be part of the standard rapid workup of a patient like this to exclude other causes. And the most common, I think, would be an acute viral hepatitis, possibly a chronic viral hepatitis and not be previously diagnosed. But my own instincts is that in this young individual, there would have to be some concern about the chelating agent. And My understanding is that 30 milligrams per kilo per day would be quite a substantial dose. If all these other tests proved to be negative, there was no evidence of acute hepatitis, acute autoimmune hepatitis, Wilson's disease, the DILIs that I've mentioned, you'd have to stop the drug. And the drug to stop would be the deferocerox. That would be the most likely culprit. So that would be my interpretation of the findings. And I would want to do this fairly rapidly because of the hazard posed to this young individual.
Thank you. So in your practice, so currently, as per the guidelines, we follow up like SGPT once in 3 months currently. So is that your practice as well, or do you do it more frequently for children who are on deferocerox?
I think once every 3 months would be standard practice. That would be reasonable. But if these have been rising to levels of 320, they're more than 5 times the upper normal. This would demand, I think, an immediate attention to what might else be causing the liver injury, rapidly exclude those or include them if there was an etiology found, and then the consideration of a DILI, a drug-induced liver injury, with, in this case, the chelating agent, and make the switch, an appropriate switch. I think I would also add the prothrombin time to the test you've done, and I would add a serum albumin, because a prolongation of the prothrombin time and a falling albumin would be of great concern that this is a very severe liver injury. And I might include an ultrasound as well, just to make sure that there's nothing incidental, such as a gallstone or something else that could explain the liver times. But this requires very close, very assiduous monitoring and possibly a change in chelator.
Okay. So that is very correctly said. That's what we would also follow at our centers, that a liver dysfunction, and then you ask for a liver function test per se would give you the albumin, and we would gently follow it up also with a prothrombin time to see how the synthetic functions are. So what if the patient wasn't like symptomatic, and this is just a transaminitis that was picked up on our liver function? When should we actually stop chelators? Till when can we wait for the chelators, for the liver enzymes? What is your practice?
Well, I would regard the chelator here as a potential culprit of DILI. So the fact that the patient is asymptomatic with raised transaminases is really neither here nor there. If the patient were to become symptomatic with evidence of a fulminant hepatic failure, vomiting, or clearly symptoms of hepatic decompensation, encephalopathy, that would be too late in my book. The disease has advanced too far with too much liver injury, which is potentially fatal. So this kind of rise in transaminases, if you had been monitoring the transaminases frequently and assiduously, and you saw a rise, and I don't know how long this patient has been on the chelators, but my understanding is from the liver tox database that the deferocerox toxicity usually occurs fairly early. But if I was to see a rise, I would want this patient coming in for transaminase measurements at least twice a week for the next fortnight to monitor the trend, and to monitor the trend in prothrombin time and bilirubin. It may be that they're transient and they settle, because this does happen with chelators sometimes. But I do think these sort of patients need measurement of transaminases and prothrombin time bilirubin twice weekly at this point in time if they've risen from near normal values.
Okay, thank you. So that's to understand correctly, asymptomatic also transaminitis. If we encounter transaminitis, we are required to repeat it at least twice a week with a prothrombin time to see the trend and then decide what to do about it. So most of the DILIs will end up stopping the drug and monitoring and wait for the counts to the transaminitis to come down before we re-challenge. So in the initial evaluation, to exclude other causes, you've already mentioned that we would look for infections as well as other conditions which are not related to thalassemia at all, for example, like Wilson's disease. So in a case of in a patient who's had a DILI with deferocerox, would you, like, are there situations where you would not want to re-challenge deferocerox at all?
I would not want to re-challenge for that drug. I think it poses too much hazard. for an individual. I think once, if this is considered a DILI due to the drug, I would not re-challenge with that drug personally.
So you would continue on deferriprone and desferal injections, if I'm correct.
Yes,
Okay.
yes,
Because
yes.
for us, desferal is a big commitment for our as in for to get a pump, to get the drug, to get the family to adhere to that. It's a big responsibility. So many patients may not accept it, and many patients may not be able to get that subcutaneous pump also. So that is a challenge for us, and it's very good to know that your recommendation that if you have a delay with deferoxamine not to re-challenge. Thank you. So now coming to the next question, which is our next scenario, which is viral hepatitis, which like was mentioned by Mrs. Sully in the beginning, it's a very common scenario. It's not uncommon at all. And especially in the last one we heard, we have had a lot of cases being reported where transfusion transmitted infections have been reported in many parts. And partly because of, we all blame the non-availability of NAT testing. But the sad fact is it's not just NAT testing. We do not have and a good quality, good ELISA also at times. So it's just a rapid testing that happens in many primary level care, and which is, although discouraged, it's still being practiced. So viral hepatitis, Hep B, Hep C is not uncommon at all in our scenario. So this is again another patient who has come in with just transfused. The next visit, she's found to be more ectric. And then when you screen her for the viruses, she's found to be HBsAg positive and HBC IgM positive and a DNA as well positive. So how do you evaluate? So in a setting where a patient comes with a positive HBsAg, what are the next things that we should look? How do we know whether this is a chronic HBV which is flared up because of an antecedent, some other infection or a drug-induced liver toxicity, or is it like an acute HBV infection currently? How do we define?
Yeah, there's a good questions, and I'm. It's always you are the real world essentially, and out there you're still seeing still acute and chronic hepatitis B acquired through transfusion, which we see very, very rarely now. However, the enzymes are very high in this patient. Her ALT is 540. She does have a positive IgM anti-HBC. Those are pointers to this being an acute de novo hepatitis B. They're not infallible because we know that some patients who have flares in chronic hepatitis B, which can be severe, will also sometimes have a positive IgM anti-HBC. So it's not infallible, but the IgM anti-HBC does point to this being an acute de novo. She's 17, so the likelihood is that if this is acute, she will in time clear the hepatitis B virus. What I would do in this patient is I would measure the HBeAg and the anti-HBe. Patients with acute hepatitis B, generally when they present to us with symptoms and ALT of 540, if they have lost the E antigen and are either E antigen negative or seroconverting to anti-E, that's a good poor man's test that this acute hepatitis B is going to resolve and they will lose HBsAg. So you can say it and look clever with some reasonable certainty to a patient who you're pretty sure has acute B and has lost E antigen, that in time they will recover and lose HBsAg. But the onus is on you to monitor this patient now and to follow the patient down until the transaminases have normalized and the HBsAg has been cleared. That it should occur in this patient, but I can't be 100% sure. If she does have chronic hepatitis B, or if this develops into chronic hepatitis B, she will, of course, remain HBsAg positive, and that will be a different scenario, and you'd have to regard this. The old definitions of chronic hepatitis B was only proven by an HBsAg that was positive in serum for 6 months to apply, although I don't think we would wait for as long as that. I would hope that this patient clears HBsAg, that she's E negative when you test for E antigen, that the DNA is on the way down. You say the DNA was positive, but you almost certainly have a quantitative HBV DNA as well, and that should decline with every new measurement. So she'll need monitoring perhaps once a week. You'll have to measure the transaminases, again, the prothrombin, bilirubin, and keep monitoring the HBV DNA if that's accessible to you. With luck, she will clear HBsAg. If not, this is unfortunately chronic hepatitis B, and it's very difficult to establish whether she is a young individual who has recently acquired Hep B, which has gone into chronic Hep B, or whether she was infected at birth. This is a flare, as you pointed out, and it's an acute flare-up of her chronic hepatitis B. But in that case, we can still help her with antiviral therapy. This would be a patient in whom, as soon as we think this HBsAg is not being cleared, and that will damp down the acute or chronic hepatitis B, and for the rest of her life, until we've got curative therapies for Hep B, she should be on a nucleoside analog. So this patient can be assisted.
So I think in a routine viral testing, so do you actually ask for only HBsAg and anti-HCV antibody, or would you ask for like anti-HBC IgM in your testing? I believe there are patients who, sorry, yeah, please continue.
I think HBsAg is useful. Anti-HCV is a good test for acute hepatitis, chronic hepatitis. We don't use the IgM anti-HCV. I don't think that's of great value. If someone was considered to have an acute hepatitis, we would also, I think, want to test for hepatitis E virus. And in young individuals, we might want to test for cytomegalovirus, acute hepatitis A, etc. It would depend on your background population. Many people in India would have been exposed to hepatitis A at a young age and might have antibodies to hepatitis A. But the epidemiology is constantly changing with improvement in socioeconomic stances. So I think you want to rule out all the viral hepatitis in an acute case from A to E. In a chronic case, the ones to test for would be HBsAg and then antibody to hepatitis C. And if HBsAg is positive, E antigen, E antibody, HBV DNA, anti-delta should be ruled out as well. In someone who's hepatitis C antibody, you want to quickly check for hepatitis C RNA. And they're both treatable conditions, so we need to establish chronic disease and treat it.
Thank you. So could you briefly tell us about, so the good thing, the only saving grace in this whole scenario for us is that there is a national program called National Viral Hepatitis Control Program, which gives molecular testing, which is HCV RNA as well as HBV DNA can be given to the patient free of cost without any without paying for the test. And the antiviral is also given from the government free of cost. So because of which, over the last few years, we've been able to get sustained response in a lot of patients who have been treated. So what are the indications in hepatitis? If you can briefly tell us on Hep C versus Hep B, how do you decide to treat with antivirals and what is the duration of treatment?
Well, all patients with chronic hepatitis C who are RNA positive are candidates for treatment, almost without exception. Even those with acute hepatitis C are very well managed with antiviral therapy. The cure rates are so high for antiviral therapy, and the costs, etc. So there are really no contraindications to treating chronic hepatitis C, and if the government is paying, all patients should be treated. Hepatitis B is a little bit more complicated. The WHO guidelines and some of the recent guidelines suggest that patients with a chronic hepatitis B who have raised transaminases and have an HBV DNA concentration of greater than 2,000 are candidates for treatment. There's little doubt that those patients are at risk of progression. However, in some parts of the world, including China, and I think even where I work, there has been a shift towards regarding any patient who is viremic for chronic hepatitis B, in other words, has an HBV DNA that is elevated and aminotransferase elevated, should be treated for their chronic hepatitis B. So I'm not sure what the Indian national guidelines suggest. It's, I think, very clear that if the DNA is greater than 2,000 and the aminotransferase is raised, patients should be treated. If the patient would like treatment at lower levels of DNA and ALT, we are not denying them treatment. treatment is very inexpensive and very safe.
Yes, the same here. Like we do not treat all our hepatitis B. It depends on the AST level. Whereas we treat all our hep Cs, whoever is RNA positive, they get the treatment with one of the antivirals which is approved. In a patient who's been started on chelators, who has started for treatment with antivirals, is there any modification of chelation that you would do in such patients? In patients who are on treatment for viral hepatitis?
For chronic viral hepatitis, I would think very little modification is required. Hopefully the chronic viral hepatitis in the case of hep C would be cured within 8 to 12 weeks, takes care of that. For the patient with chronic hepatitis B, the nucleoside analog should bring the HBV DNA down to undetectable within 3 months. So I would think that there would be little concern about just treating through with the iron chelation, perhaps reducing the dose if there was any concern. But by and large, I think iron chelation can be used as a treat-through treatment during chronic hepatitis. For an acute hepatitis that's proven to be acute and very severe, perhaps the chelation could be held for a few months until the viruses have cleared. But for chronic hepatitis, I would treat. Does the risk of HCC reduce after treating hepatitis C? Yes, it does. It's reduced by about 70 to 80%. We know, however, that patients, by and large, who have advanced fibrosis or cirrhosis, before they are cured of their hepatitis C, still have a residual risk of HCC. So we continue to monitor all our cured patients with hepatitis C who are known to have cirrhosis, generally established by a FibroScan above 10 or 12, for HCC afterwards until something teaches us better, because we've not eliminated the risk of HCC after cure of hepatitis C. That risk is very, very small in patients who did not have cirrhosis before they were cured, but there is a residual risk, quite hard to quantitate, in patients who did have cirrhosis before they were cured.
Yeah, thank you. One more doubt regarding that. So in a patient who is treated and cured of hepatitis C and we have stopped the drug, the standard practice is to repeat the RNA around 6 months later. Is that what you would also do in your practice? Or do you repeat it initially 6 monthly and then annually? Or would you, if there is no cirrhosis, how do you follow up?
We tend to do the test at about 12 weeks, 3 months, a little bit earlier, but 6 months is fine. And then we discharge the patient if the RNA is negative and they did not have cirrhosis before the cure. If they have cirrhosis, we don't discharge them. We keep them under HCC surveillance. It's quite a big burden for us because the numbers do increase and we have to have good surveillance systems in place. But in our current state of knowledge, we don't discharge the cured hepatitis C patients who we knew had cirrhosis and portal hypertension beforehand.
Now coming to the last case of today. So this is I'm sorry, just the slides went up and down. Yeah. So this is a young adult who has been poorly chelated earlier. So this is again one issue, again to highlight that because there are doctors from across the country who have joined in today. Many times when we see families who are coming in from primary health centers taken care of by organizations also, many times the emphasis is on transfusion. So they're beautifully transfused and they do not have a splenomegaly, but somehow the acceptance of chelators are very, very poor. Then at the drop of a hat, they stop chelation. For every fever, they stop chelation. So many times this is what happens because of that. So by the time they're like 18 to 20 years of age, their liver dysfunction, their cardiac dysfunction becomes so profound that often it becomes, there's no going back from there. So this is a 25-year-old boy who has presented with quite advanced issues, severe hepatic iron overload, ferritin of 7,800, ascites, hepatomegaly, like one of the pictures that you had shown, hypoalbuminemia, elevated INR. So just coming back to the prevention part of it. So in T2 star MRI, how frequently are you advising MRI? So to your question regarding FerriScan versus T2 star, we have access to T2-star much more than Feriscan. I think that's probably because of the cost involved. And even T2-star is also not easy to get. Probably there's 1 or 2 centers in every big city that would be doing it. That's just about it. So, and it's that also is quite costly. So in your practice, how frequently would you advise for a liver monitoring? At what age are we to start monitoring with T2-star, and how frequently?
I hope I heard all the question. I would just adhere to the very well promulgated guidelines because I live and work in a country that is endowed with resources. And my colleagues who look after the thalassemia patients, I think, would do an MRI T2 at annual intervals. And they would use the ferritin regularly to see the trends. So the two are sort of complementary. The ferritin alone is not relied on. They do use the MRI. I didn't quite hear your question about access to MRI T2-star. You said that's difficult to obtain in many parts of India.
Yeah, R2 versus T2-star, it's T2-star that we have access to. But even that is the access to an MRI is quite poor.
I think with regard to the ferritin, I think you can place reliance on trends in the ferritin, and you showed a ferritin in the earlier slide of around 7,800. That's high. And this 25-year-old man, I think, has not been well managed from the point of view of reducing the iron burden in the liver. As you said, the emphasis has been on transfusion, keeping the hemoglobin up, keeping these patients well, but there's been a cost. And that cost, unfortunately, is very advanced liver disease with ascites, hepatomegaly in a very young individual. This is the real world. I accept that, where the emphasis has been on giving the blood, but not getting rid of the iron. And I suppose, I don't know how many retrospective measurements of ferritin are available in this patient, but was there a steady increase in ferritin throughout life that we can call on to see that this trend in ferritin was obviously reflecting an increasing iron overload in the liver? To the extent, and I don't know what other factors may apply here, this was a very young man with decompensated cirrhosis. And
Thank
again, data from countries like India to know, what numbers of patients are reaching care with decompensated cirrhosis. I imagine the thalassemia population by and large is quite well monitored. But the question to ask is what numbers of patients are now presenting with liver disease and hepatocellular carcinoma? It's really an important question for the thalassemia community. And we can't extrapolate from what we're seeing in Europe, but it really has clearly a different disease and burden in India and other parts of the world.
Yes. So I believe Dr. Eleftheriou has to leave. So I would request her for her comments, and then we will resume the rest of the questions. Is that okay?
Of course.
Thank you so much, Professor Duszejko, and thank you, Dr. Nida, and all the participants for this insightful and interesting questions. My concern is that there is still a lot of out-of-pocket payment on certain tests that are necessary. We've been talking about MRI testing and about elastography. And I think that that's a preventative measure that we need to take care, because patients may be doing on the one hand out-of-pocket payment, and on the other hand standardized MRI measurements. We know these are challenges everywhere that we need to take care as far as standardization is concerned. But out-of-pocket in paying these is a significant preventative measure for regular monitoring, as the guidelines suggest, and as Professor Duszejko does. So, and India has done so much progress in improving the services for these patients through the years. But it is a pity to remain on certain levels suboptimal because patients are aging and then suddenly they start developing serious and severe medical complications that are due to perhaps not frequent and reliable and standardized monitoring. So we need to, all of us, try to improve these as well. And I'm sure there's a lot of work going on. So on the other hand, there is so much progress being done in eradicating viral hepatitis, in treating holistically hepatitis like hepatitis C. And I'm very happy to see that antiviral drugs are free of charge in India. Looking through these, we need to work out how to improve services for the liver disease and monitoring. So many thanks for organizing this. Many thanks for those answering this, for those asking the questions. And Professor Dusheko, thank you so much for being with us. I hope, Dr. Nida, just before I go, that all these conclusions that you derive from all this series of webinars, we can put them together in a sort of booklet, in a sort of reporting, in a sort of report, so that we can go through, and then next year we can see what progress we've made. Many thanks for giving me the floor and the time, and thank you, Mrs. Chu, for being.
I just want to make a comment here with Dr. Neeta's permission.
Yes.
Yeah. So Dr. Dusheko has mentioned about data collecting on the liver disease in India. So I'm not here talking only about India being a part of TIFF, So this is something very important. So how can we collectively having TIFF there on the top, and then in association with such countries from where such kind of data, where they're struggling with the challenges. Do you think there is any possibility that there could be some joint collaborations?
I hope and pray for such possibilities, because we've been trying for many years to see, the establishment and the development of databases, of registries, trying to see published results. I think we need to think and develop tools, at least in our collaborating centers like this center. And if we get, we cannot do it nationally across a country, because we do need national registries and nationally coordinated and funded projects. But because India is a big country, and there is a great number of patients in many centers, I think if we work and develop a consistency in the collection of data that need also to be reliable data using the same standardized machines, we need to see how we can collect data, because the quality of data, I'm sure Professor Dusheko would agree, everybody would agree, that the quality of data is important in order to make any assessment. So I think, Mrs. Tulip, we can work with centers like this, which have a lot of patients, and with others with even bigger numbers, 2 or 3 centers, and collect consistent and reliable data within next 3 years, for example. Then I think we can make a good assessment. But we need to work on what kind of data, quality of data, consistency, and numbers.
Yeah, I agree with you that we cannot cover the whole country.
No.
But as far as India is concerned, we have now 2 centers, which are the collaborating centers.
Yes.
Neeta can take the lead, and she can be in this with the joint efforts and all that. Maybe, Dr. Neeta, we can just concentrate on few states, not the whole of the India. And then we can need to sit down. And second is about, Dr. Neeta, that we need to sit down again, and we have to talk about the rapid testing. When we are talking about the blood safety, that's another part. Because in some states, where there's a lack of ELISA and the NAT, so that they are using the
lack of ELISA, are you sure there's lack of ELISA? Because that's the simplest, cheapest test. Probably lack of NAT testing, yes? I agree with you.
This is what sometimes the government officials say, that there's lack. So we need to sit down. These are the two things, Dr. Nita.
Yes.
I wanted to, talk about this in the presence of Dr. Dusheko and presence of Dr. Nrula El-Fitrio, that jointly we have to look at these two issues and perhaps we can do something about that. So
Yes.
thank you so much, Dr. Nrula. So
we are committed to support this, and if Professor Dusheko is with us, I'm sure Dr. Nida do not need to ask. She's with us, she's passionate, and we are only privileged if Professor Dusheko joins in this initiative.
I want to make a last comment about TIFF. I remember that the TIFF guidelines, the consistent organization of the TIFF conferences outside India, as well as in India, which have been organized and supported by TIFF, that really made the difference in our country, and especially in the countries like the developing countries in the other countries. So thank you so much. These are
Thank you. Thank you very much. And I'm very happy that TIFF can support in this way. But let me make a last comment. India is no longer developing. We see there's a big power globally. Thank you so much, everyone. Have a nice weekend. Professor Dusheko, thank you.
Thank you.
Thank you. Thank you, Dr. Eleftherio. And coming back to I think this can be the last question, Professor Dusheko, on when you're following up a child in the clinic with liver disease, what are the markers? Like you mentioned albumin and prothrombin time. What else can you look at to suggest progression? Do you routinely keep them on follow-up with fibroscan? So what should we do in our practice?
I think if you have access to fibroscan, that would be useful. It's been validated to a degree in thalassemia. The transaminases may obscure results sometimes, but most of the time, I think you could use what you suggest, the albumin, the liver function, the AST to ALT ratio, which is sometimes reversed as liver disease advances to cirrhosis, the prothrombin time. But a good non-invasive way would be regular fibroscans, perhaps every 2 years, depending upon your clinical concerns. But I would think that should be pretty simple and portable. And once you've got the capital cost for a fibroscan, it's very easy to use. We use it very widely in following our patients.
I'll stop sharing and just quick questions from the chat before we wind up. I think there's probably only one question on what would you prefer for patients who are having fever while they have liver cirrhosis? What is the drug that you use, paracetamol or an NSAID?
So NSAIDs are dangerous drugs in patients with cirrhosis, advanced liver disease, because they have an effect on renal blood flow. So these patients are very susceptible to renal injury. We try to avoid NSAIDs in patients with advanced liver disease. Paracetamol, as you know, in large overdose can cause fulminant hepatic failure, but small doses of paracetamol for a fever in a patient who doesn't have advanced liver disease would be my choice.
I think we come to the end of our scenario, for case scenarios and questions as well. And I would request Mrs. Toli to give the final remarks. And from all of us here, a big thank you to Professor Dusheko for painstakingly answering all our questions. I can see one more question. What is the role of as an Desperal in hepatic dysfunction? How do you monitor as well as modify doses?
Well, I think you probably have more expertise than I do, but the one that would be the problem would again be defercerox, because that's metabolized by the liver. It is hepatotoxic, and we don't know the mechanism of hepatotoxicity. So I think that would be the one to avoid, and we could use the others. Some are metabolized by the kidney, some are metabolized by liver, watching liver function very carefully. But hopefully you'll be able to get some of the iron out of that diseased liver. Hope that answers the question.
Yes, sir. Thank you very much. Over to you, Mrs. Tuli.
So first of all, thank you so much, Dr. Dusheko. And nice meeting you once again and on such an important topic of the liver disease. And I think all the delegates must have understood by now after hearing Dr. Dusheko's expert inputs and the comments that the ideal situation is the prevention. So the patients and the parents have to focus on the good health and leading to the quality of life. And as far as India is concerned, I just want to say that the incidence as compared to the last years, it has really decreased. And this is all because of the guidelines, the Indian guidelines from our Indian experts, as well as the TIF guidelines, which are available and accessible, as well as the awareness, which we are trying to create through the workshops and the conferences, and of course the improved use of the vaccinations which are available and the improved treatment as well. So with these words, I would like to thank once again Dr. Dusheko and of course TIF also being a partner for holding these eco webinars, and special thanks to my colleague Dr. Neeta Radhakrishnan, who has been an excellent speaker and a moderator and coming out with such important case studies. And thank you, ECO, also for hosting this webinar. So I would request Dr. Neeta if she can talk about what is going to be the next topic of our next.
I was actually going to ask you to announce it, ma'am. So the May 6th is the date. I wish you could give an announcement regarding that.
You can do the announcement, please.
So next webinar, so we are because it's like almost end of March. So we're doing the next session on the 6th of May, 2 days prior to the International Thalassemia Day. And we have Professor Maria Domenica Capellini, who is going to be speaking to us on newer drugs in thalassemia. There's been a lot of interest in new drugs in the last 1 year. Luspatercept got approved for use in India in adults. And as well as there is a lot of data, a lot of people, a lot of doctors as well as patient groups want to know about mitapivat. So we have requested her to talk to us on what are the newer drugs. And from India per se, there is a lot of data which has come out on thalidomide, and there are studies which have come out now. So I think, so we'll put up a panel discussion at the end of it after her talk with Indian experts on their experience of using the newer drugs.
And Dr. Neeta, Dr. Nrula just commented that India is no more a developing country. So I think it's a big challenge for all of us, all the clinicians and the patient communities, that we have to really, make these messages spread across our country that, well, treatment is available and they have to, even if it is out of the pocket or through the governments. So I think in the coming few years, we all should try our very best that the treatment is available free of cost in the state, through the state governments, and whatever best policies can be initiated through the central government. So these words, I would once again like to thank each one of you for your time and for your presence. And special thanks to Dr. Dusheko, please. Thank you so much.
Yes, sir. Thank you, sir. Thank you to all.
Thank you very much. Bye-bye, everyone.
Bye. Thank you.
Thank you, ma'am. Bye-bye.
Thank you. Thanks for the meeting.